help watch the chat line too, okay?
That's right.
And look, it even says it on the slide. Uh-oh, somebody hasn't done it.
It happens.
Well, it's not even 8 o'clock and we have 116 people. Check that. And it grows. All right, Bill, Ben, you ready? Everybody's listening?
We're always ready, Lewis.
I love it. All right, I'm going to start. Good morning, everybody in virtual Grand Rounds land. This is Lewis First, and I want to welcome you to a very special Pediatric Grand Rounds on this April 1st, and I'm not fooling. But I thank everybody for tuning in for a virtual town hall on COVID-19. Before we get this going and explain the ground rules, I think I'd like to say many of you may have Zoom bingo cards in front of you. If you are playing Zoom bingo, the mute your audio box can be crossed out now.
And Dr. First, sorry to interrupt. I'm going to mute all right now and you will need to unmute yourself. So I'm muting everybody and please unmute yourself.
Perfect. All right, I'm here. So first of all, we got everybody muted for the moment. Let me make a couple comments before we get this going, and then I'll turn it over to Drs. Lee and Roska and to Dr. Zuckerman to facilitate what we're about to do. First of all, thank you to all of you for essentially everybody on this call and around the state are unsung heroes for working to bend the curve and doing everything we can do to treat children with and without COVID and their families and each other. And protect us. And I could not be more grateful for everything everyone is doing. I have never seen a more supportive pediatric community rallying, whether you're in the community, whether you're in parts of New York, whether you're in Vermont, or wherever you're tuning in. There is an enormous amount of love and virtual hugging that goes on each and every day, and we need that. And I just thank everybody for just keeping the lights on and making us an example, I hope, for the rest of the country of how to do this and do it well. So thank you for what you're doing. From an educational standpoint, we are going to try to inform. We had some out-of-town speakers for this month. On the Grand Round schedule, you notice that we're going to give you 3 out of 5 this month. The next 2 weeks, there will be no Grand Rounds, at least at the present time. If something comes up or we need another town hall, we may be able to put it in and we would notify everybody accordingly. The beauty of virtual Grand Rounds is you don't have to go very far to tune us in and we'll be right here. But your schedules right now say no Grand Rounds again until April 22nd. If that changes or this session requires us to put something else back in, and if Drs. Roska and Lee want to come back, you never know. Or other aspects about COVID care from abuse. Again, we're on guard for issues of domestic violence, child abuse, and many of the other issues that we have to pay attention to, in addition to the infectious disease ones that sit front and center. So I thank you for all of that. Third, we've muted everybody. For those of you who tune into the 4 days out of 5 weekdays, the pediatric calls from 12:15 to 12:45 that VCHIP puts on with the health department and the Vermont Medical Society and the AAP chapter. This is sort of one of those blown up. You know that Drs. Lee and Roska are on there to answer questions, and the action box is the chat box. So they may give you some ground rules, but we're going to use the chat box today. If Drs. Roska and Lee want to open or take a question, they'll be working off the chat box to get as much information out and to play to your needs. Whatever questions do not get answered, we will make, as they do on the noon calls, we will work to get you, everybody who's on or has registered in, we can send out the list of questions that weren't answered during the course of this hour, because we cannot touch everything. And it may be teed up to tell us what we're going to do another town hall about in one of our free spaces for grand rounds. So it's a little bit of a different forum, but use the chat box as the talks continue, unless Doctors Roska and Lee tell you otherwise. And with that as background, I'm going to do very quick introduction, because since the day in, day out, all of us have been on the front lines trying to be there for our patients, for ourselves, and to answer questions. And I can't think of two people who've been answering more questions for us than our infectious disease division of Bill Roska and Ben Lee. So I thank them at the start of this. We'll thank them at the end. And they will be watching the chat line with Dr. Zuckerman. But again, both of you guys, thank you for stepping out. Bill, where are you today to broadcast to it? They're doing social distancing, so you can identify your sites, and off we go. So thank you for giving us a town hall on COVID. Welcome.
Thanks, Lewis. Thanks for inviting us to present today. And I'm excited to see everyone. So my background's in Lao, but I'm actually in my office today. So we're going to go through a couple of things today. This is not an exhaustive presentation on COVID-19, but we're going to do a skeleton and hit a couple hot button topics, and then we're going to make sure that we have plenty of time at the end to answer some questions. So again, we'll rule biology, we'll spend a bit of time epidemiology, some clinical findings, and then we're going to talk about testing, healthcare workers with ill contacts, and then PPE.
Bill, you're cutting in and out.
All right, how about this? Can you hear? All right,
that's probably better.
Disclosures. Neither of us have anything to disclose. Again, the ground rules, you've heard a little bit about this, but everyone's going to be muted. Continue to ask questions in the chat box. Whoever is not presenting will actually be trying to answer those questions. And while question answers at the end, you can use your raise hand icon to do that, but also you can use the chat box. And again, as Lewis mentioned, we're going to try to make sure everyone's questions are answered.
And Dr. Raska, for some reason it is still cutting in and out. Is there any way you can move a bit closer to it?
This is how's this?
Yeah, you've been so good all week. I don't know why you're cutting it out. Maybe the number of people are making the transmission. We have over 200 people now, Bill. So we can only take 300, and then it's going to lock out. So that may be part of it. You have a lot of people on the Zoom line.
So there is just one more thing. Somebody suggested, in case it keeps cutting in and out, that you could try calling in by phone as well for the audio piece of this.
Okay, well, let me know. Just keep on letting me know if things are not working well. I'm trying to use the hotspot, the connection here at the university rather than my home. I thought it'd be more stable, and it turns out maybe it isn't more stable.
And there is a suggestion for everybody to turn off their video who is not presenting, because that might make it better. So let's turn off our videos.
So these are, we're going to talk about coronaviruses today. These are common viruses. They cause lots of human infections. As we all know, they're the cause of the common cold. And they can also cause mild to moderate lung disease. And there are lots of animal reservoirs, so coronaviruses can infect many different animals. And spillovers between human and animal populations can happen, and sometimes with really severe consequences. Many of us remember SARS, the severe acute respiratory syndrome coronavirus infection in 2003, which was associated with a significant amount of disease in Hong Kong and Canada. Middle East respiratory syndrome coronavirus in 2012. We didn't hear as much about it in the United States, but it was a big event in the Middle East and parts of Europe. And that actually had a very remarkable mortality rate of over 40%. And of course, what we're struggling with now is COVID-19, or also known as coronavirus disease of 2019. And again, this is the bat. That those of you who've seen the movie Contagion, I've noticed that bats have been frequently invoked in these crossover events because they actually support multiple viral infections at the same time. I have one slide on pathophysiology, and I put this up here for a variety of reasons. This is the structure of coronavirus. It's an RNA virus. It has some proteins on the surface of it. Some of the vaccines technology, some of the vaccine strategies are actually trying to look at these inner aspects of the capsid and actually the genome, the genome-based vaccines. But if we look on this side of the screen, we can see these spikes, these S protein spikes, and they actually mediate attachment to a receptor, the angiotensin converting enzyme 2 receptor. It's a transmembrane receptor. And I mention that because this protein is expressed in a variety of cell surfaces, oftentimes in the lungs, but also the heart, kidneys, and intestine. And that may explain why some people will have kidney issues, some people will have gastrointestinal complaints, but it also, and this understanding will lead to some advances potentially in therapeutics. Can we develop antibodies to these S proteins? Can we develop antibodies to this attachment? And that might prevent infection or ameliorate infection. Switching to epidemiology, the timeline is just amazing. So it was first identified, or let's just say first acknowledged at the end of December. The first US case was January 20th. Seems like a lifetime ago practically. But big events, February 20th, we had community transmission in Seattle. Remember, before then, it was always associated, thought it was associated with travel, but it was the first time we really recognized that this was spreading extensively in our community. And on March 26, 2020, the United States officially had more cases of COVID-19.
And Dr. Raska, I'm sorry to interrupt you. It's still cutting in and out. Would you mind trying without your headphones? Could we see if that would work? It might be the speaker on the headphones.
As of February 26th, we had more cases than anyone else in the United States. This is a map essentially of the United States. And you can see that we've had a lot of cases, 163,000 cases across the United States. But you can see some interesting trends here. A lot of disease on the coast. You can see New York City has a huge percentage of the cases. But about half the counties in the United States actually are not reporting any illness or no. You see that the coasts and then a lot of the urban and environments are really overrepresented in the United States. This was not surprising to those people who monitor the epidemiology. Everyone's heard about curves with comparing the United States to Spain, Italy, and China. And again, curves are easily misinterpreted. We have a lot more people in the United States than Spain or Italy. But just this rate of rise is just a terrible, it's a terrible curve. And we see this happening, and it's still going on in the United States. So cases, but not all. This is the Vermont data. This is as of yesterday. We had 293 positive results reported. That's about a 7% rate in Vermont right now. And you can see in a map of Vermont, Chittenden County, which is our most populous county, has most of the cases. This is a curve that you can see on the Vermont Department of Health website, and it just shows the number of cases, new cases, and cumulative cases over time. There are some really nice things about this curve. It's just a very nice graphical representation, but it's also, right now, it appears to be an arithmetic curve and not a logarithmic curve. And so in different parts of the United States, they're seeing doubling every 2 days or so. We are not seeing this at the present time. We are preparing for that, but this is actually kind of reassuring a little bit that we're seeing 30, 40 new cases a day, but we're not doubling every 2 days, which is happening in different parts of the United States. Why that's going on, it's a little unclear. It could be that we're a rural state, and it could be, however, that the measures that have been put in place have actually flattened the curve. People have heard about flattening the curve. The theory is that if there are no protective measures put in place at all, lots of people will be infected at the same time. You'll have a huge number of cases all occurring at the same time. And of course, the big event there is that you overwhelm the healthcare system capacity. If you put in place measures to decrease how many people get infected at the same time, you stretch that out. Still, people become infected, but it's over a longer period of time, and that you're able to care for those people. So how about children?
So Dr. Raska, I apologize. Sorry for interrupting. Let's try to fix the audio issues.
National data. This is the international data for Germany, where they do lots of testing. So aggressive testing program. And what you can see here is the background rate. Children, only about 0.7% of the German population between 0 and 4 tested positive for COVID. 5 to 14 is about 2.3%. Again, a very aggressive testing program. This is in 18,000 people. In Korea, they also have a very aggressive testing program. And what we can see here, I don't know if you can see, I certainly can't see it right now, but in Korea, about 0.7% in the youngest population, and a couple percent, around 4% in the 10 to 19 age group. In US data, this was published by the CDC and MMWR a little over a week ago. You can see that children make up a very small proportion of people hospitalized. So less than 1% of the total population that required hospitalization. We actually have data from Seattle Children's Hospital as of the 25th of March, and they tested 919 symptomatic pediatric patients, and only 6 patients were positive. That's a 0.7% rate. 2 were hospitalized, both with underlying conditions. And I'm very appreciative to the epidemiology branch of our state health department. As of yesterday, the state had tested 150 symptomatic pediatric patients between 0 and 15 years of age, and there was a single positive patient for a rate of 0.7%. In the 15 to 19-year-old group, we've had a few more positives. We have about 6 positives, I believe, for a background rate around 5%. What this really suggests is that our local data is very consistent with the national data, which is very consistent with the international data. And that really suggests that pediatrics is relatively spared. Children can get infected, but this is really much more driven by adult populations, and that we are seeing far fewer patients in our patient population than the adults. Switch over to Ben now to continue our discussion.
All right, good morning, everybody. Can everybody hear me?
Yes.
Yes, we can hear you. And I'm going to very briefly mute all again, and Ben, you will unmute yourself. So
Okay.
Okay. Everybody is now muted.
So the challenge, so I know that there a lot of folks were having issues with being able to hear. And so part of the challenge, I think when Bill, as we're learning about Zoom, one of the issues is as Bill is going through his slides, he actually isn't able to see the chat. So Bill, just to get you caught up a little bit, there were some issues with volume during your portion of the talk. And I think what we'll do is I'll go through this next section. If there are specific parts of Bill's first section that people want to re-review, we should have plenty of time in the Q&A that we can touch on the highlights.
And while you're doing this, Ben, I'm going to switch computers.
Okay. But similarly, while I'm going through my presentation, I actually can't see the chat box. So Anna, feel free to jump in if need be, if there are any issues with my with my portion of the talk.
Will do. Thank you.
Okay. All right. So what I wanted to talk about next was some of the clinical aspects of COVID-19 and how this relates to us in pediatrics. So first, starting with the incubation period, it's believed that the incubation period can be quite lengthy for this virus, with the range of anywhere between 2 and 14 days. So that's where the 14-day quarantine recommendation comes from in people who may have been exposed, is that some people, it can take up to 2 weeks to actually present with symptoms, even if they're infected. Although the mean generally tends to be right around 5 days. So most people will present within the first week, but there is a longer lag time in a minority of patients. And what we do know is that for most people who become infected, the degree of infectiousness or contagiousness does appear to drop off fairly quickly after day 7 of illness. And this is what drives the current CDC guidelines regarding when people can stop isolation if they don't have access to testing as a way to prove when they've sort of cleared the disease. It's important to note that this will apply to most, although certainly not all. It is generally agreed that once people start to show improvement of symptoms, that the viral loads do tend to drop off pretty quickly whenever that time should occur. In terms of clinical findings, most of what we know comes from the adult population. And unfortunately, with this virus, it has been harder to pin down a really consistent and specific clinical case definition because the manifestations can be quite variable. So depending on the paper you read, these percentages may be quite different. And that's been one of the challenges. But certainly some of the more common findings are fever, malaise, sore throat, cough, and shortness of breath. Those are sort of the most classic findings, although whether or not they're all present at the same time can be a little bit variable. By and large, the severe cases that we worry about are the ones that cause severe lower respiratory tract infection or pneumonia. So that would be significant cough, significant shortness of breath, increased work of breathing, hypoxia, etc. One of the symptoms that has been increasingly reported is loss of taste and smell. It's still unclear what percentage of affected patients will have this symptom. However, this is appearing consistently enough that it does appear to be a significant aspect of this illness. And this is probably something that is worth asking about. We have anecdotal data, even from within our own center, that a not insignificant proportion of cases will complain about this, particularly early on in the course of illness. As I mentioned before, in most folks, things tend to get better within the first week, but we do know that there's a subset of patients, mainly adults, those who do go on to develop more critical illness often will have a pattern where they appear to have mild to moderate disease for the first week, but then have a subsequent worsening. So that's why it is critical to continue to do very close monitoring of people throughout the course of their illness. But by and large, it's generally accepted that very roughly about 80% of all cases will be considered mild. Again, there are a lot of challenges because the definition of mild can differ quite broadly depending on which studies you look at. But the vast majority of cases will be mild, with a minority showing moderate to severe manifestations. And this is also true in pediatrics. These are data from a large case series reported from China. This was recently e-published in Pediatrics. What's important to know about this data set is that these are children who had a known exposure. Most of them were known household exposures, meaning a sick parent or adult in the house. So in this context, we do see that the age distribution is a little bit more equal compared to what Bill was showing earlier. Whoops, sorry. However, once again, the vast majority of children had what was defined as mild or moderate disease. So again, it is becoming more and more clear that in children, this does tend to be a rather mild disease. Now, that doesn't mean that we won't have some subset of children who couldn't present with severe or critical disease, particularly those with underlying health conditions. But for otherwise healthy children, this does really appear to be a mild illness. Unfortunately, the only way to definitively diagnose COVID-19 is by testing based on the lack of specificity of the clinical findings, as I just alluded to. And as you all know, this has been extremely problematic in the United States. Most of this has to do with lack of test kits and all the associated components. So that means collection devices, the test kits themselves, and all the ancillary reagents and tools that are needed to actually run these tests. Because of this bottleneck, in the United States, up until just very recently, and even currently still in most places, the priority has been on testing high priority patients, meaning almost without exception, those who are symptomatic and at higher risk, meaning those who are hospitalized or may have underlying health conditions. And unfortunately, this has been so variable by state and has been subject to so many changes that this is one of the challenges in terms of really trying to pin down the true epidemiology of this disease here in the US. As you can see on the figure, in terms of per capita testing, the United States still lags far behind many countries that are much smaller than us in terms of population size. This is starting to improve, but we're clearly not there yet. And finally, the actual test characteristics remain unknown. All of the tests that are currently being used are nucleic acid-based tests, which in general have fairly good sensitivity, but it would be nice to know what the true test characteristics are. And now that we have a combination of CDC or public health lab tests and commercial tests, it's actually hard to know if the characteristics of each individual test are similar or not, because we just don't have those data. So here in Vermont, right now, to review sort of indications for testing, as I mentioned before, we really are prioritizing testing for those with moderate to severe disease. For example, hospitalized patients, healthcare workers with signs and symptoms consistent with COVID-19, and specific high-risk groups, including immunocompromised individuals and those with specific underlying medical conditions. Now that we have a number of centralized testing areas set up, we do recommend, if at all possible, trying to refer patients to those centers as a way of conserving PPE for local offices, rather than having people come into your office and collecting specimens there. Now, we all have heard that our health commissioner has put out a call for more liberalized testing. That the intention there really is for that to mainly apply for the time being to the adult population. And so in children, we are still recommending that we focus on those with severe illness or those who have underlying risk factors. And most of that has to do with the epidemiologic data that Bill showed earlier, in that children, and particularly young children, do appear to be at very low risk for having this disease. So if we can't test and we don't have a great clinical case definition, at the end of the day, the one thing that all of us can do reliably is preventive measures. And this really gets into our basically social behaviors. So the first rule of prevention is keep sick people from circulating in the population. So if anybody does have any form of respiratory symptom, it is really imperative that those folks are not out and about. And we've heard a lot about social distancing and keeping one's distance. Because of the way this virus is generally believed to transmit, that is crucial. People should stay as far away as possible. But going hand in hand with that, no pun intended, is the importance of good hand hygiene and the importance of washing high-use surfaces frequently. There is concern that fomite-based or contact-based transmission, even if not the most significant means of transmission, can happen. And so if everybody is washing hands diligently and washing surfaces diligently, that's another barrier of protection. And so finally, when we talk about this on a societal level, we get to the concept of social distancing. So obviously, the photo on the left shows a pretty poor example of social distancing, whereas on the right is maybe they're doing a little bit of a better job. I will, go on record here by saying, there's absolutely no doubt in my mind, or really I don't think in the mind of any experts, that social distancing does have an impact. and is absolutely crucial and imperative in terms of our overall response to this pandemic. The challenge is that the effects may take a while before we really start to see them in significant volume. So patience is a virtue here. I'm only gonna, in terms of treatment, I'm only gonna say we really don't have any treatments, particularly for children. There are ongoing trials. I will caution folks that the data that are available for the agents that have received the most press coverage, hydroxychloroquine and azithromycin, are very scant and conflicting. And I think there are trials in progress. There are protocols that have been set in place for potentially using these agents in inpatient settings. But I will say that currently there are no data for any treatment that has proven benefit for COVID-19. All right, and so finally, to shift gears, in our last set of slides, hot topics. So first, management of healthcare workers with ill contacts and management of PPE. So this is obviously an important question that affects all of us here. What to do with healthcare workers who have an ill contact at home. And I'd first like to just review sort of our general approach to sick children in the household. Now, it's important once again to remember that there is a very, very low background rate of infection with this virus in children. And in general, the younger the age of the child, the less likely they are to have COVID-19. Because of this, at this time, we are still not recommending routine testing of all children with signs or symptoms of respiratory illness, even if they are a child or household contact of a healthcare worker. A healthcare worker who is exposed to a child with respiratory illness who hasn't been tested, right now, the general guidance is that that healthcare worker can continue to work without restrictions if they are asymptomatic, but it is imperative that they do very, very careful and honest self-monitoring for development of symptoms. This is something that we do have sort of a consensus on between us here at the center and with our colleagues and contacts at the Department of Health. If there is a child who either is higher risk or has a more compelling epidemiologic reason for being tested and does test positive, the general guidance here is that that healthcare worker can continue to work, but in the setting of a contact with a known proven positive, that they should wear a surgical mask in that condition while working. And again, as long as they remain asymptomatic, with careful self-monitoring for symptoms. Now here at the medical center, any decision about work and work restrictions is going to be made with the guidance of employee health. So this is not a question or issue where if anybody is in this scenario that needs to be done in isolation, at least for those of you who are joining who are part of our medical center. Now,
Dr. Lee, there was a quick question about what your definition of child is. Is it up to 18, up to 15 in this discussion?
Yeah, so for our purposes right now, we're still likely calling this 18. In general, the rate of positivity creeps up just a touch in the the 10 to sort of 20-year-old population, but it is still low. So we're for right now we can feel confident using just the standard definition of 18, and that is something we can discuss more if people would like a little in a moment later. Now the scenario is a little bit different when it comes to ill adults in the household. So for most healthcare workers, this may be in the context of a spouse or partner. In adults, the background rate of positivity is a bit higher if the adult is symptomatic. And so this, I think, would be the perfect scenario to take the health commissioner up on his call for perhaps expanded testing in adults who may have more mild manifestations of disease and aren't sick enough to be in the hospital. If there is a healthcare worker who has exposure to an adult with respiratory illness who's not tested, it would be reasonable to say, okay, go ahead and test that contact. But while waiting for test results, there still is no recommendation that that person has to be restricted from work as long as they're asymptomatic and are doing good self-monitoring. Now, if the adult contact is a known COVID positive, again, the general guidance is if the healthcare worker is asymptomatic, that worker can still work, but should wear a surgical mask and do careful self-monitoring. Again, this is a scenario where a case-by-case sort of evaluation with the assistance of employee health would have to be done. And there may be exceptions to this general guidance based on extenuating circumstances. And so this is not necessarily a one-size-fits-all answer, but it is the general guidance. Okay, so with that, I'm going to turn it back over to Bill. Hopefully we'll have a little bit better luck with volume this time, and I'll stop my screen share so Bill can get back on, and I will get back onto logging the chat box, to monitoring the chat box.
All right, so can people hear me better now? And Ben, I'll let you monitor the chat box and see what the responses are. How is the first volume check?
It's great.
Okay. I am very sorry that people were unable to hear me well during the initial part of the presentation. Really, the take-home point from that was that internationally, the background rate of positive test results in children is quite low. And the 0 to 10, it's less than 1%. And then 10 to 20, it's just a couple percent. And that's consistent with our national data and our local data. And that in Vermont, in the population 0 to 15, we only have about a 0.7% positivity rate in symptomatic children. And in the 10 and the 15 to 20, we're closer to the around 5%. But again, that's very consistent with national and international data. So I'm going to talk about transmission as it links to the use of personal protective equipment. And as you can imagine, this is a really controversial issue. And I have asked Scotty to put up the Teflon shields. I have full deflector shields on right now. But to think about this a little bit, we have to think about how this virus is transmitted. And what we really want to emphasize is that this is respiratory droplet. This is primarily driven by these large droplets that are spread by coughing, are sneezing immediately close to you. Smaller droplets can go a little bit farther, 3 to 5 feet. And that is the basis for our general recommendation that we do social distancing and people stay at least 6 feet apart. A second concept that's really important is that this is really close contact. This is not casual contact. That even in really high intensity areas, the transmission rate is still only 30 to 50%. That's even in intense family exposure. So generally speaking, this casual contact, just walking past someone, is not an effective way to transmit the disease. As you know, there's been lots of data that the virus can survive on a variety of surfaces for a variable period of time, anywhere from 4 hours on copper to maybe 2 to 3 days on stainless steel. And again, we can detect that by nucleic acid hybridization tests. And again, we can detect the virus. How viable that virus is a little less clear, but nonetheless, it forms the basis of why we recommend washing surfaces all the time. So we have always recommended washing down your laptops and your phones at the beginning and at the end of the day. And of course, there are these aerosols we worry about when you do an aerosol generating procedure like intubation, that you can put these particles in the air and they can remain suspended in the air for 1 to 2 hours. But we're not saying that this is airborne transmission where particles can remain suspended for long periods. So
That's not what the CDC is saying.
So a huge issue really is, is there asymptomatic transmission? And over the past 2 weeks, one of the challenges for us is that asymptomatic and never symptomatic, asymptomatic and pre-symptomatic, and mildly symptomatic have all been conflated in the media. And again, it's just there, for a lot of people, it just doesn't matter that much. It's what's the risk for me getting infected if I see someone who has no symptoms? But and when we're trying to do epidemiologic studies, those are really very different populations. But we have really struggled with how likely it is that someone who's asymptomatic and never symptomatic is transmitting the disease. So in the chat box on noon calls, what we have said many, many times for pediatricians is that in pediatrics, we have a very low background rate of positive results, and that children are not driving the pandemic. They really aren't. So asymptomatic children, whether they remain asymptomatic or pre-symptomatic, are not the drivers of the pandemic. So what's the likelihood of transmission from asymptomatic infections remains just hotly debated. It's unknown. Some of the best data comes from the Princess Diamond ship off the coast of Japan. And again, that is not reflective of the general population at all. These are people that were quarantined, and before quarantine took place, they were all on the ship and they were allowed to do things together, okay? And then they were, yikes. So, and again, from there, the models would suggest maybe that 15% of the transmissions was driven by asymptomatic people. So again, we debate a lot about dissemination by contact, but again, close contact was certainly a good way. Fomites, droplets, aerosols. And again, it gets down to the question, you know, do you decontaminate? Do you wash down the food that you buy at the grocery? And again, lots of advice on CNN about whether to do that. But realistically, from healthcare worker perspective, the question isn't, you know, what's the relative risk? What are the mathematical models? The question is, should I wear a surgical mask or any other type of protection when I see a patient? And again, I put this up because this is how the CDC approaches this. And when they think about hierarchy of controls to prevent transmission and to protect healthcare workers, you'll notice that there are lots of things that they want us to think about. First, the elimination, but these engineering controls, you know, administrative controls, you know, isolating people, changing the way we approach our patients. And again, PPE is way down here at the bottom. All these other things are really important. So when we talk about triage, screening, and how we move patients through our facilities, those are all critical. And again, this is down, the personal protective equipment is down here at the bottom of the hierarchy. So as you can imagine, this has been a really hot topic about how to manage PPE. The top part of the slide that you can see is really just from a couple days ago when, you know, mayors across the country were pleading for more equipment. Many of the institutions were down to just a couple days of supply. You have nurses in a city hospital in New York pleading for masks, whether it's an N95 or other masks. But again, just last night, the two bottom pictures are from news reports last evening. And again, it's just remarkable how quickly this has expanded. And now people are saying, should everyone wear a mask? And even the president of the United States has weighed in on that. Anthony Fauci, who said the NIH as well, if we had an infinite supply of masks, he would be very comfortable with everyone wearing masks. But again, at the local level, that hospitals have their own policies in place. And again, it's led to, at times, an adversarial relationship was really important, where healthcare workers really want to be able to wear a mask, and hospitals saying we have to conserve masks. And this is just an individual who was sanctioned by his hospital for wearing a mask in a home. Last week, there was a survey of infection control specialists. And again, at this point in time, you know, they just said like in 12% of the centers, they were completely out of face shields, just out. And again, almost a third reported being completely or nearly out of face masks. So again, that drives some of the decision-making that's going on. I put this slide up because as we've been monitoring the chat box on the noon calls with VCHIP and CHAMP, you know, how to use PPE, when to use PPE has been a subject that has come up on multiple occasions. And there's just really conflicting advice and what you hear. On the left side of the screen, you know, the World Health Organization, as of yesterday, reaffirmed its commitment that masks should only be used in ill people, and there should be no routine use of masks. National governments have very different policies. Some national governments have issued masks, 2 masks to each family member. Some Eastern European countries yesterday said you have to wear a mask to go out. Sweden doesn't wear masks at all. Healthcare advisory groups, so the CDC is not recommending routine use of masks, yet healthcare specialty groups would say, well, we want to protect our specialty group. Otolaryngologists seem to be at high risk. In the general public and amongst others, there's fear and anxiety. And when we think about whether or not to wear a mask, we have to think about patient preference. And again, in each institution, there's a culture of whether or not to wear a mask. There are physician preferences. There are supply issues. How much of a supply do we have? Do we have, 3-day supply? Do we have 10-day supply? What's the pipeline like? Will more be entering? And again, the size of the healthcare workforce plays a role. That if you're in a network where there are 30 or 40 physicians, that may have a different impact on your decision making than if you're a solo practitioner and there's no one behind you. The positivity rate in the population, so we in pediatrics are relatively protected. We've said in Vermont, in the population 0 to 15, only 0.7% of symptomatic children have COVID. But if you're seeing adults or older adults, that might change one's perspective. And again, what is the best available evidence? And there isn't great evidence at all. And then what happens is institutions actually put these numbers into a burn rate calculator, and they can say, oh my gosh, we have enough for a week, but if we change these parameters, we have enough for 3 days, or we have enough for 30 days. So all these sort of things are being filtered into the command. So there's to be incident command here trying to figure out how best to manage PPE, or your hospital or your practice group trying to figure out how to manage this. It leads to really radically different approaches. So the Seattle Children's Hospital says universal masking of workforce is not warranted. They specifically state, we have good environmental controls. We do not issue masks. You should only use surgical masks when they're indicated. Boston Children's Hospital, another august institution, but a member of the partners group have said universal masking for all employees, and all employees get a mask for the shift. So you go, my gosh, radically different approaches. So at each individual level, do I wear a mask or not? You have to say, well, how effective are masks at preventing transmission? Is it preventing me from infecting a patient? How important is it for that patient? Will the mask prevent the patient from infecting me? What's the probability that any child is infected with the virus? How significant is asymptomatic transmission? Should I wear a mask in a totally healthy child? How does the critical national shortage of PPE influence by decision-making? Currently it's a zero-sum game. So if I use a mask, there is one fewer mask for my adult colleagues. How effective do I think my environmental engineering and administrative controls are? Do I trust them? How do I manage ambiguity? And of course, what level of risk am I willing to accept? All these things come into play. So what's the Vermont Children's Hospital approach? Again, we assume we need to protect healthcare workers. We have to work within the preference of the network, and Dr. Leffler had said that we need to conserve masks. And we have assumed a PPE shortage, and that was as of noon, March 31st, although there was a FEMA shipment to the state of Vermont, evidently over the past 48 hours. And again, we have a low background rate of positivity in the pediatric community. As of yesterday at 4:30, there was a very unclear role for homemade masks. And here are a couple homemade mask people in the faculty meeting heard about Laura Ashley. This is the mother of the chairman of the molecular biology group, sort of a Laura Ashley design there. I have no financial relationship with Laura Ashley. I'm not supporting Laura Ashley at all. But again, it's unclear. Homemade masks are not as effective as surgical masks, but nonetheless, when there's a true shortage, could we potentially use them? And again, we have lots of rigorous environmental administrative controls. People entering the hospital have to be screened for cough and fever. And then, so our policy has been to use surgical masks. As indicated, we have not advocated universal masks, and we've been really trying to identify low-risk situations where people feel comfortable not using masks. This is just an algorithm that we put together with pediatric primary care to say, well, can we identify situations where we don't have to use masks? And again, many of the primary care physician offices are having well visits in the morning. And again, if you have good environmental controls, you could screen all the patients. And if they're totally asymptomatic, the child's totally asymptomatic and the parent is totally asymptomatic, the family doesn't have to wear a mask and the provider wouldn't have to wear a mask. If there's any illness, you would direct them to the ill clinic. But clearly, if there's signs of respiratory illness in a child, you're going to put a mask on that child, or if there's a sign of respiratory illness, you put a mask on the parent. And again, we have models to say when we would use masks. This is one way of addressing the problem. Now, this is just a meme that I put it up there. It was circulated a week or two ago. You know, it's just like JACO, when you get this hustle-based organization, you know, they come around, you got scotch tape on the wall, you get a citation, and now they're saying, okay, you can use any piece of cloth over your face. And this was sort of kind of it generated a bit of laughter. But again, late yesterday afternoon, this is just breaking news. The Joint Commission issued this 4-point statement saying hospitals need to conserve PPE. That's good. We all agree on that. But they said, privately owned masks and respirators, that they're donated to doctors, organizations. How important are they? But they say it could be that's important. But then they very specifically say that there is no Joint Commission standard or other requirement that prohibits physicians from wearing PPE brought in from home. And they don't really define it. And later on in the statement, they say that homemade masks are not necessarily PPE, but then they actually go on to say homemade masks are an extreme measure and should only be used when standard PPE of proven protective is unavailable. And they don't really define exactly what that is. So that's breaking news. And it could be that more homemade masks will be used in the future. So Ben and I have gone through a lot of data. We want to make sure there's time, but I want to give a shout out absolutely to the Department of Health. Brina Holmes and Sally Cook. Brina's on the call every day. I can't thank them enough. We are in a luxurious situation that we're able to work with the health department continuously. We have wonderful access, and I can't thank them enough. Wendy for organizing the calls every noon. The Adult Infectious Disease Service, Cindy, who's in the incident command, just wrestling with this every single day in Camp Alston, infection prevention. To all of you for your flexibility, and of course I can't thank Ben enough for all that he's done. So I'm going to stop here, and hopefully we'll be able to answer some questions. And again, a question has always come up: are you going to get COVID from your dog? I think it's unlikely, but there you have personal protective equipment for your canine. And I'm going to stop sharing.
So if anybody has questions at this point, feel free to click on the raise hand feature. I can start with a few things. There have been great answers coming through the chat box, but one question that came up is our hospital protocol of taking temperatures when people walk in. So taking temperatures, I wonder what percentage of COVID positive patients are febrile. Having few people touch every person who enters the hospital in series seems like a risk in and of itself.
So in theory, there should be social distancing while doing that. The people who are doing the screening should be using appropriate gear and protection to do that. The sensitivity of a scan is not great. That in the adult population, the majority of people who were initially identified or symptomatic have had fever, but that's not a universal finding. But it is an objective finding, and that you can imagine that people who desperately need to work or want to work may say they do not have a cough, and people who potentially, you could say, so there is bias in how people could potentially answer the cough question, but the temperature is objective, and we try to prevent the people doing this, who are doing the screening.
Thank you. Another question that has come up in various iterations is how to approach the parent who brings in the child, knowing that parents have a higher rate. Should we be masking asymptomatic parents? Could you address that? So,
so again, different people will look at this a little bit differently. And again, we're in a luxurious situation here that, the children are not the real drivers. So assuming a PPE shortage, assuming a situation where there isn't enough PPE for everyone, if the adult is absolutely asymptomatic and through rigorous testing and screening, however that is defined, is totally, completely asymptomatic, then we have not routinely recommended masking that adult. If that adult does have symptoms of respiratory illness, then of course, and that is the designated adult with the child, then it would make sense to mask the adult.
And I'd like to just jump in and comment as well. And really, a lot of the discussion and recommendations coming from our center about PPE and when to use it, et cetera, they're being made with the long game sort of in mind. just because of the recognition that resources are limited, and how can we best preserve them for, how can we best preserve our stores for when we're going to need them most. So we recognize that it's there's not going to be a perfect strategy that's going to be able to address all scenarios. If PPE supplies become no longer an issue, then certainly guidance could be changing, and but a lot of it just really hinges on supply and projections for our needs over this next month.
Another question that came up is the correct technique for swabbing. Is there a minimum amount of time that you need to leave the swab in?
So to the best of my knowledge, there isn't a minimum time. There's interesting data from the Seattle influenza study that it didn't really matter where the healthcare provider did the swab or the parents did the swab or self-swab, it all worked pretty well. And so that may be one of the reasons why there's a recommendation that you can do an oral pharyngeal swab, a mid-terminate, or a nasal pharyngeal swab. You just want to make sure you are touching some surfaces. So just if we use the analogy of the throat culture, if you're doing a throat culture, you should make sure you touch the pharynx and the tonsils and swab that around. As long as you do that, it should work.
Thank you. There was a question early on that came up about why kids are less likely to transmit this. Is it because they have less of a strong cough, like with TB, or they're less likely to have lower respiratory tract infection, or some other mechanism?
I don't think we really understand the transmission from children to adults very well, and we just it is relative. It's not totally clear why children just don't have the same burden of disease. It could be that receptor, and that's the reason I put it up there, that there's differential expression of the angiotensin converting enzyme receptor or different modulation of it. So it is, and I've sort of lost my track here, but again, we're just not sure exactly how that's going on, to be honest. So I would say the first thing is that we just don't see as much disease in children, period. So therefore, they're not going to transmit as much disease.
Thank you. There's been some discussion in the chat box about children with asthma and whether they're considered high risk. And somebody also asked, what about children with cystic fibrosis? Are they at high risk and more likely to be tested with symptoms?
So the easier answer has to do with children with mild to moderate asthma, and the pulmonary service here and the ID service here has not been putting them at higher risk. Children with cystic fibrosis, I would put at somewhat higher risk. We are testing patients with cystic fibrosis who are symptomatic, and particularly if they're being going to be hospitalized.
If anyone has additional questions, feel free to type them in now and we'll read them out. We have 3 minutes left.
So there's a question about the commissioner's high level concern based upon the number of deaths so far. So the commissioner was very grim yesterday at noon. He was very worried about the number of deaths. We have an older population. The deaths have been primarily driven by people in the 80s, to be honest with you. And the commissioner wants to do everything he can to protect that vulnerable population. There are different models about the surge in Vermont, and I think everyone is really trying to prepare for that as best we can.
Thank you. There's another question that came up in the chat box, but I wonder if you could comment on, which is the concern that until we develop a vaccine, won't we just have resurgence of this once the social distancing measures are relaxed?
So there are, go ahead, Devin, go ahead.
Yeah, so sorry, I had addressed that in the chat box. I can review sort of what I had said. So yes, so I think, at the end of the day, one of the things that we're trying to do is just buy as much time as possible until we can get an effective vaccine, because that would be the one best way to basically take care of this entire problem. It is conceivable that that we'll have to go through multiple rounds of social distancing. They're already seeing in Asia, in places where they sort of relaxed a little bit, suddenly new influx of either travel associated or local transmission. And so that is a concern. the part of this that will be a key consideration is how long will it take until we can also get universal testing available in the United States? Because if we're in a scenario where we can very aggressively test anybody we want, whenever we want, as they were able to do, for example, in South Korea, then the extent to which we need to, or how we respond to this could be very different. And it could mean that even though we have to go through multiple rounds of so-called social distancing, et cetera, of how extreme those measures are may be different depending on how aggressively we're able to quickly identify and isolate new cases. So a lot of this right now really is about trying to buy time, for lack of a better term, until we can get testing capacity to the point where we can do universal testing, and until we can get potentially effective vaccine candidates.
I'm gonna jump in for just a moment because we're at the witching hour. I want to thank Drs. Roska and Lee. This is a continuing set of questions and answers, and it will change. So a couple things. First of all, we will try to synthesize, as you've asked for, the themes of the questions, provide answers. They're asking if you would share your slides. We're getting some nods, and Ben, I assume so as well. We will do that. In terms of distribution, we may send that, and if Brina and Wendy are on, probably through the same listserv that we're using for the noon calls, because we set a record today of 287 people for this grand rounds, where we could get to 300. And so you get a sense of the need in this state and upstate New York to want to get these things out. Unfortunately, I'm not sure we have a roll call of how many of you were on, who you were. So you can either call our office once we have something to share. You can email Penny Marchessault, marchessault@uvm.edu, or me, and we'll get this turned around, but we'll try and get it distributed with the minutes of an upcoming call at noon and to our medical staff. And for the medical staff, next week, while there's no grand rounds, there will be a pediatric medical staff meeting. We'll be polling you in the next day of whether you would like to do it at 8 a.m. or 9 a.m. since there's no grand rounds. And we'll let you know by hopefully Friday afternoon which of those 2 hours will run the medical staff meeting. Again, thank you all for what you're doing. This is a continuous discussion. Things will change, but we will be right here with you, taking care of our kids and taking care of each other. Thank you again for a superb grand rounds. Lots of questions. Got a decent amount of some good answers, but it will change. Thanks for all tuning in, and we'll be back with you with the grand rounds in 3 weeks, maybe sooner, and a med staff meeting next week. Have a great week, everybody, and don't forget the noon call today, 12:15, with the Department of Health Academy and VCHIP. Bye.